Welcome, everyone. Thank you so much for inviting me here to speak. I see a lot of friends in the audience, and I really want to start out by thanking Dr. An. I've known Catherine for maybe about 5 years. We crossed paths, early on as I was finishing fellowship, and I've always admired your pursuit of continued education to see what we can do, how we can learn, what tools we can implement for the betterment of our patients. And really the purpose of our being here together today is for all of us to come together and to really learn from each other through discussion and dialogue and case studies and case examples to see how can we take it to the next step. And so really that's the theme of my talk this morning, is how do we move beyond the standard of care? The current standard of care being waiting until there's a problem, until there's a disease, before we start to recognize that disease and start to offer palliative interventions. Rather, we're all here today to really look at this problem from its inception and to discuss and learn how can we help these patients in a collaborative, interdisciplinary fashion. And I'm so honored to be here with you guys here today. If you want to copy my lecture slides, it's available via the QR code. My name is Dr. Soroush Zaghi, a medical director of the Breathe Institute. I'm a graduate of Harvard Medical School, UCLA ENT residency, and Stanford Sleep Surgery Fellowship. And our goal at the Breathe Institute is to provide patient care, research, and education towards a comprehensive, interdisciplinary, and functional approach to pediatric adult sleep and breathing disorders. We're looking at the structure, the physical obstructions, but also the function and the long-term behavior that dictates that function. And to that extent, I'm so proud to have Dr. An as one of our affiliates and fellow colleagues who's taken extensive training with us to build this model here at Aviera in a very similar vision. And I'm so proud to be here at the facility and see not only the beautiful structure that you have, but the personnel and the team and the staff you have that allows it to function with such a great mission that you've kind of set forth as its director here. In a functional approach to sleep and breathing, I hope that you will all agree that we want all patients to breathe well. We want everyone to sleep well so that they can function well. That's our goal, plain and simple. We want to optimize health and wellness for all patients through prevention, early identification, management, and definitive resolution. And to that extent, if we want all patients to function well and sleep well, I hope that you will agree with me that breathing is the beginning. For breath is life, and if you breathe well, you will live long on earth. The current standard of care waits until patients are in their 70s and 80s with anxiety, depression, loud snoring, headaches, neck and shoulder pain, high blood pressure to do a sleep study and say, hey, now there's a problem. This is the perspective from the medical community. The perspective from the dental community is to say, oh, look, there are all these dental manifestations of disease that we can restore and rehabilitate. But perhaps another approach would be to take a moment to discuss how these problems arise and what we can do to prevent them from the start. Because Dr. Belfour mentioned yesterday, you don't wake up one day with sleep apnea, right? It often starts with an AHI less than 5 events per hour. It often starts with mouth breathing, minor blockages to the airway that can contribute to upper air resistance, snoring, and it's the increasing airway resistance due to inflammation and underdevelopment of maxillofacial structures, as well as physical changes in the cortical gray matter and brainstem that result in decreased cortical arousability that manifests this progression from mild, moderate to severe disease. Let's watch this in this baby. This baby was born with torticollis. Torticollis is a condition in which the sternocleidomastoid is under a lot of tension and spasm. It pulls on the extraoral fascia, it pulls on the intraoral fascia and causes low tongue position. This child here has low tongue position. I don't think you can hear the audio here. Is the audio up? Let's try here. Let's try the audio. Let's pause for a second here. Let me get the audio up. Should I have the audio go to the projector or AVR Wi-Fi?
One sec, James is done.
All right, so let's watch. Baby's born with mouth breathing. Okay, can't sleep on the back. Everything's normal. Pediatrician sees this baby at 6 months. Maybe you can turn the sound up a little bit. Again, there's no problem here, but this is a problem. This is where the problem starts, with that low tongue position. And then she develops positional sleep disordered breathing, only on her back. You guys can see she continues to have low tongue posture. You can see that she's developing an underdeveloped maxillofacial skeleton. But this problem is for now only on her back. This is not normal, but a sleep study may fail to show the problem. Because on the night of the sleep study, she's going to sleep on her face. And she's going to compensate for this problem and get a negative sleep study. Because this positional sleep apnea, only when she's in the supine position. Yet as she's sleeping on her face, you ask yourself, what's happening to the development of that nose? Do you think that nose is going to grow straight with this kind of pressure force? Or do you think it's going to deviate off to the side? How do you think the face is going to develop? We talk about, underdevelopment, right torsion, left torsion, shift. Well, how do you think the face is going to develop if you constantly put pressure on one side versus the other?
Is that a home sleep test or is that at a lab?
In-lab sleep study.
Okay, my question is, at a lab, would a technician observe that and say, okay, honey, I need you to, let's get back on your back, or do they just let the child?
Depends on where you do it, but in an in-lab sleep study, they're looking for sleep apnea, and sleep apnea requires them to stop breathing and have oxygen loss. So if they're not losing oxygen, just arousing, they may not pick it up.
Would they at least note, hey, child snoring?
Yeah, so oftentimes they'll note mild snoring, mild mouth breathing, otherwise within normal limits, right? And then, so the problem there is, yes, so you never want to say mild snoring, right? That's a problem in and of itself because that is obstructive sleep disordered breathing. So again, going back to the slide, they're looking for moderate to severe sleep apnea as an indication for initiation of CPAP. But we want quiet, exclusive nasal breathing. And if there's any noisy breathing, I would have written the note, very concerning snoring and noisy breathing. Right? If you say mild, occasional moderate, only when she's on her back, otherwise within normal limits, it's giving you a false picture, presentation of this picture. So here we watch this girl as she goes from low tongue posture to mouth breathing at 6 months, to noisy breathing, positional, and then ultimately, severe sleep apnea. And we witness this cascade everywhere we go. Who here has noticed this in their communities, that there's a progression that goes back and forth? And so we're here to really identify the smoke that precedes the fire of this upper airway resistance. And oftentimes, even before you have any UARS, before you have any arousals, the most common signs of this problem actually lies in the teeth, especially with clenching, grinding, and sleep bruxism, often even precedes upper airway resistance. We did a study in which we assessed the etiology of sleep bruxism in pediatric dental patients. And we identified that 80% of the time, 80% of the reason why kids clench and grind comes down to tonsils, nasal obstruction, and tongue tie, okay? In this study, we were able to show that if they did not have any large tonsils, if they did not have any tongue tie, if they were nasal breathers, yes, there is some chance of sleep bruxism, potentially related to stress, anxiety, pain, malocclusion, microarousals, all these different etiologies. Yet, if they had 3 out of 3 of these issues in terms of tongue tie, nasal obstruction, and large tonsils, they had about a 90% or greater chance of having clenching and grinding. And perhaps the one that had no sleep bruxism was because this was based on parental report as well as clinical signs and symptoms. We have shown that patients with, let's go forward one, that patients with large tonsils have a 50-50 chance of of having sleep bruxism. If you have a tongue tie, that predicts higher for sleep bruxism than even tonsil size. Isn't that interesting? I was talking to Bill for yesterday as well. We have the data. I don't know if I can explain it. People ask me why. Why does the tongue tie cause this problem? And I struggle. So I'd love to kind of learn from you if anyone has a thought or suggestion. And then nasal breathing. When you have nasal obstruction, one thing you could say certainly for nasal obstruction and tonsils is that you have an upregulated autonomic nervous system, stress, fight or flight. Do you guys have any thoughts? Because we've shown that this is related to the problem, and we've also shown that when you treat tongue ties, we have a 91% improvement in clenching and grinding. Any thoughts as to why that might be?
Well, the tongue position is totally critical. So what I'm thinking is when you have the tongue tie, that automatically means the base of the tongue is in the airway, and that automatically changes the head posture.
Yes.
So they're now they're malfunctioning
Yes.
completely. And if I'm not the expert on the anatomy, but if you look at the relationship to the tongue, to all the cranial structures and all the structures in the body, it's intense.
It really is.
That's what Tim was talking about yesterday. One thing is linked to the other.
Absolutely.
It's definitely a postural issue.
A postural
Most
issue,
recent
pulling you forward.
literature, 2021. Clenching is definitely postural.
Got it.
Tongue postural, body postural, what it is.
Beautiful.
That sends signals to the vestibulocochlear system, horizontal gaze system. Now they're
Got it.
sleeping, but there's positional things going on.
Yes.
So that sends those signals to vestibulocochlear, what to do.
Wow. Amazing. 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 So now that we know this, now that we know that, these problems are there, what are we going to do about it? This 4-year-old presents for a routine checkup. He has a crossbite. He's got dental wear and facial asymmetry. This is affecting not only his mouth, but his entire health and wellness. You'll note that he's the 10th percentile for weight and 25th percentile for height. This child is not sleeping well. He's not getting into deep stage 3 sleep, where you have the release of growth hormone, which is important for not only growth, but also immune function. We take a look inside his mouth and we see that certainly he has the large tonsils, he has the dental wear, he has the nasal obstruction, and he has the tongue tie. There's no surprise that this child has a problem with sleep disordered breathing. So here we're learning about the impact of tongue tie. And, in other lectures, I would, start by explaining how the tongue is important for speech. You have to lift the front of the tongue to make the TLND sounds, the back of the tongue for the RSKG sounds. For the sake of this more advanced group, we're going to kind of take it that it's accepted, right? That everyone agree you have to move the tongue to produce speech, even though that could be a 1.5 hour discussion in and of itself, right? The other thing that we'll say is the tongue is involved in chewing. I don't have to convince you guys that you have to move the food bolus side to side. And if you have a tongue tie, you're not going to be able to chew, especially in the back. And it's that chewing function of the back teeth that plays a big role in the facial development. Swallow, I don't have to convince you guys that you need the tongue mobile in order to swallow, but also oral hygiene. You need to move the tongue around the teeth to keep the teeth clean and the mouth closed. What we're going to be talking about today is what does the tongue have to do with sleep and breathing, right? It makes sense that it has to do with speech and swallow, but what about sleep and breathing? And the way that I answer this question is by talking about what it takes to be a good nasal breather. In order to breathe through the nose, 2 things must be true. Number 1, you must have a patent nasal passage. Let's think about it. Your nose has to be open, free and clear of any mucus or obstruction in order to breathe through your nose. You guys all agree, right? If you're blocked, it's not going to work, okay? Nasal obstruction is one factor that plays a role in nasal breathing. The other factor that is often overlooked is the role of the tongue. The tongue must go up in order to divert the air in and out of the nose. When the tongue is down, the air comes in and out of the mouth. In this way, the tongue functions as an on-off switch for nasal breathing. When the tongue is up, the switch is on for nasal breathing. When the tongue is down, the switch is off for nasal breathing. Let's prove that to ourselves here. With the tongue up, try it yourselves. The only way to breathe is through your nose. It's impossible to breathe through the nose, through the mouth when the tongue is up. Whereas when the tongue is down, you're going to have mouth breathing. Literally, the only way you can breathe through the nose is by pulling the back of the tongue up so it reaches the soft palate. If you have overaggressive UPPP surgery, uvulectomy, NightLase, and it's too aggressive, and you have a tongue tie, that patient's going to become a mouth breather. You need to have soft palate to tongue contact in order to have good, efficient nasal breathing. Now, if you have a tongue tie, that tongue is held down. Yes, they can lift up the back of the tongue to do nasal breathing, but it's going to require a lot more increased respiratory effort. These patients will be mixed nose and mouth breathers. Sometimes breathing through the nose, sometimes breathing through the mouth. Yet we want nasal breathing more than 96% of the time. If you're breathing through the mouth 15% of the time, that's mild, 30, moderate. More than 30% mouth breathing is considered severe mouth breathing. If you're 50-50 nose and mouth, that's very severe mouth breathing. To that extent, we're recognizing the role of the tongue in increasing the amount of effort that is required for nasal breathing. You guys agree, right? So let's take a look at this case, and I'll ask you, is this child with naturally optimal tongue position nasal breathing or mouth breathing? The tongue is up. It can only nasal breathe with the tongue up. Whereas this child with a tongue tie, the tongue is down. Where is the air coming in and out of? In and out of the mouth. In and out of the mouth. The tongue functions as an on-off switch for nasal breathing. When the tongue is up, nasal breathing is turned on. When the tongue is down, nasal breathing is turned off. When the tongue is up in its normal and ideal resting position, you're going to get good, efficient nasal breathing, but also optimal oral function that's going to allow the optimal development of the maxillofacial complex. When the tongue is down, you get mouth breathing and all the sequela of low tongue posture that follows. When the tongue is up, you're going to develop a nice broad palate based on the chewing and swallowing mechanisms. When the tongue is low, the cheeks and lips win the game, and you get a much more narrow, crowded upper jaw with transverse deficiencies and asymmetries, as we've talked about. When the tongue is up, there's a negative suction cup effect that keeps the tongue up all throughout the night. Okay? When the tongue is down, there's nothing really supporting or sustaining the tongue. Let's take a look at this child who had a tongue tie release. Okay? This is post-tongue tie release in therapy, and you'll notice that the tongue is up. We're doing this sleeping mouth posture hold. The tongue is up. The whole system is closed. There's negative suction keeping the tongue up all throughout the night. This child is nasal breathing, and you'll see some movements of the genioglossus muscle and the tongue muscles that it just stays up. Isn't that amazing? It just stays up. And when he swallows, he's putting that force on the roof of the mouth. Beautiful. Amazing. So good. This is what we want, right? For our children. So this is the outcome that we want, not only to do the procedure, but to confirm the outcome. To that extent, when we do research, it's not only about the cutting, it's about having achieved this outcome. We're no longer comparing tongue tie versus myo. We're comparing high versus low tongue posture. Is the tongue up or down? And to that extent, it requires three things. It requires you to address the tongue tie, the tongue tone, and the tongue space. Because if there's not enough room in the mouth for the tongue is still going to come down. If the child doesn't have the habit and tone, the tongue is still going to sit low. So you can do all the tongue tie surgery that you want, but you're not going to achieve this outcome of high resting tongue position such that you have that negative suction cup effect. You need all three ingredients to get the tongue up to help have optimal function and grow the upper jaw. The tongue functions as a natural palate expander. When the tongue is down, you get problems with dental crowding, V-shaped, narrow palates, that unfortunately all too often is treated with dental extractions, missing the bigger picture that there's not only not enough room for the teeth, but there's also not enough room in this mouth for the tongue. And so myself as an ENT, I'm coming in and maybe it's a little, maybe you're seeing there's not enough room for the teeth. I'm seeing there's not enough room for the tongue. So what can we do to kill two birds with one stone? Make more room for the teeth and the tongue, okay? And the problem with extractions is that maybe it addresses the dental crowding, but it certainly doesn't address the tongue space. How can we improve the tongue space? And it's not only side-to-side problems, we also see vertical maxillary excess. And it's so amazing that you can identify these problems without even looking in their mouths. You can identify these problems simply by looking at their eyes. There are orbital findings of maxillary deficiency because the roof of the mouth is the floor of the nose, and the roof of the maxillary cavity is the floor of the orbit. Okay? So if you have maxillary deficiency, you'll have inadequate support on the lateral canthus, on the orbital rim and the zygoma. And in this case, you're going to see there's not enough support in the lateral canthus of the eye. And in this case, the lateral canthus of the eye is lower than the medial canthus. And so after treatment, you see much improvement in that regard. And we've seen similar sides by Dr. Belfour and Dr. Adams over the course of the last week. Let's take a look at this gentleman here. My question to you is, what do you think his mouth looks like? Do you think he's optimally developed, wide, broad arch palate? Or do you think this is a patient with maxillary deficiency? What do you think, Dr. Belfour?
No,
What do you think?
actually, he has superior vertical strain, which means that his premaxilla never developed. He basically, the distance between under his nose and his lip is so tiny, he has no maxilla.
Amazingly and absolutely hit it on the nail. This is what his mouth looks like. Is that incredible or what? You don't just, Dr. Bell has an eye for it, right? But it just proves the point. He's had practice, right? But it proves the point that you almost don't even have to look in the mouth, because these are systemic issues that could affect the entire face and the whole body, okay? And so let us understand that the roof of the mouth is the floor of the nose. If you have a narrow roof of the mouth, you'll have a narrow nasal cavity. And when you have a narrow nasal cavity, high arch palate, there's not enough room in that nose for the septum. The septum starts to buckle. Mild allergies will contribute to problems with severe turbinate congestion, not because there's anything wrong with the turbinates per se, but simply because there's not enough room in that nose, such that mild enlargement will cause a very significant problem. In this case, the low tongue position is associated with a high arch high arch palate, narrow nasal cavity, septal deviation, but also a lack of support on the inferior orbital rim and the zygoma. In 2017, we demonstrated that indeed, tongue tie is related to a V-shaped narrow palate. Tongue tie is one aspect of the problem. However, tongue tie is only one aspect of the problem. And even in the best research, it's only about 7, maybe 10% of the problem is tongue tie. So, yes, please.
Sorry.
No, please. This is interactive. Yeah.
So in the literature, in you know, as an ENT, do you see any indicate that just the buckling of the septum is due to insufficient radiation?
There's no papers on it.
Okay. Because
There's no
it's really not when I talk to ENTs, they're like, oh, you must get,
There's no, yeah. So
Meanwhile,
they don't have, they say just trauma or congenital, right? But what does congenital mean? They're not born with a deviated septum. It's developmental, right? So it's not congenital. It's either trauma or developmental. And if it's developmental, then how is this, right? So how is this going to create a straight nose, okay? In ENT, if you break your nose, what we do, if you're a child, we put it back, we tape it for 1 week and it stays the same. If your ears are protruded, we tape it back for a week, okay? What is sleeping like this going to do night after night after night? Going to do development of the face, okay? And how do you even begin to do a study like that? Okay, we know that cartilage remodels, we know that, right? After nasal surgery, don't sleep on your nose. Why? If you do, it's gonna get crooked again. Let it heal. These kids are actively growing, the cartilage is soft. What do you think is gonna happen? And certainly when you have the high arch palate, you're seeing this time and time again, but these topics don't lend themselves well to randomized control trials. And I think that's one of the faults of medical doctors and ENTs is they're looking for too high of a level. They want something to be proved. Whereas in dentistry and functional medicine, we're more open to learning from case series and case studies and starting there and working our way up. So as we're discussing this case, we're also recognizing that tongue tie is only one aspect of the problem. Tongue ties are important. I'm going to teach you, how we treat tongue ties, but more important than tongue tie is tongue posture, chewing, swallowing, diet, the food that you eat, okay? Mouth breathing habits, genetic factors, and more. And it's not only the nutritional value, but also the consistency of the food. Are you eating soft foods or hard foods? So we recognize that tongue tie is only one piece of the problem. There are so many things that, a few things that we understand, so much that we don't understand, okay? Epigenetic, genetic factors, diet, nutrition is really an open area that we really have to learn more about. But already, this weekend, we learned about cranial strains. We're learning to observe nasal obstruction, tongue ties. You guys learned about fascia restrictions. And for a minute, I'm going to talk about myofunctional therapy, which addresses the tone of the tongue, the ideal resting oral posture, working with the muscles of the lips, tongue, cheeks, and face. You can even do not myofunctional therapy, but oral motor therapy with amazing results. Here's a 2 years, 5 month. 2 year, 5 month baby.
5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. Look at loud. Oh my God.
That amazing or what? This is how you teach a child to breathe through their nose? All right. You start by desensitizing. These children are orally and facially defensive. They can't move their tongue appropriately. They have strong gag reflexes. You have to start in the extremities with occupational therapy. Bring them down regulate them. When their shoulders are like this, they're defensive. You have to calm them down, get them seating, make sure they're having fun, face painting, not being defensive anymore, massage inside the mouth, help lift it up. It's a lot of work to get to this amazing endpoint. And so we have the Breathe Babies and Kids department. This is Dr. Nora, and what she's doing is she's taking a look at all the babies that come in and working with Anna Gross, who's our speech language pathologist, infant oral motor specialist, as well as Dr. Pinto, to see how do we help these kids long term? How can we ensure that their tongues are up, the lips are closed, and that we're providing healthy breathing through the nose, okay? And that's where and that's just the beginning. Once we've established these factors, tongue up, lips closed, healthy breathing through the nose, we work on chewing and swallowing, because chewing and swallowing does a body good, right? So you gotta make sure that your children are chewing their food. Yet, if they have a tongue tie, right? How are you gonna ask these people to keep their tongue up? How are you gonna ask them to have exclusive nasal breathing? How are you gonna ask them to have efficient chewing and swallowing? So we see these kids who come to the pediatrician with facial asymmetry problems due to unilateral chewing, sleeping on the face, hand postures. You can just guess, right? But you're gonna see this is your future homeoblock patient. Am I wrong? Okay. But maybe we can prevent this by intervening now, by identifying the tongue tie and the habits. Yes.
Can I, so common, of course, is the problem of thumb sucking, which there are dentists out there who very strongly believe that the reason the child puts the thumb in the mouth initially is they're literally trying to correct their cranial strain, and ultimately what we see is because of the pressure of the thumb, they can literally reposition the maxilla, so which turns out to be a really big breathing problem when they're adults. So I was wondering, how do you address thumb sucking? How do you get the kids to get their thumb out of their mouth?
We have Anna Gross and Carla Giroux out of Australia who have a thumb sucking habit elimination program. That program is for ages 4 and up. Okay, so under age 4, you try to look at it, try to identify the root cause. Is it a tongue tie? Is it nasal obstruction? Is it large tonsils? Is it a habit? You can try to work with them, and then by the time of age 4, you rule out, make sure that they can breathe through their nose, they don't have any tongue ties, that they understand, and then you do like a 30-day program where you're providing positive reinforcement, no negative reinforcement, you don't draw attention to it, and day by day you kind of work on the problem. But I agree with you that if there is some way to address these problems even sooner, that would be more ideal. Okay. If from our research perspective, we want to be successful in terms of what we're measuring, and we know that we can do it age 4 and up. So let's prove it there, and then let's go 3.5, 2.5, 2. but it's a hard problem, isn't it?
Yeah.
It's a really hard problem.
Very.
So we're taking a look at this case, and I, actually love using the Chimera app on Dr. Balfour's website. I think you asked, why do I use this?
Yeah.
And the reason is that it really shows parents that something's not right. Okay, parents can understand this. It's not the most accurate 100% thing, because if you're a little bit tilted this way or a little bit tilted that way, you can easily get a different response on this thing. But it just shows you that something's not right. There's asymmetry here. There's dysfunction here. And that's the extent to which I use it. But I'd love to have your comments on what you see in this picture and what you think about how you use the Chimera generator to help your patients, Dr. Balfour.
Well, when you see one side of the face is round and the other taller and narrower, my initial feeling is that this patient is breathing into their left side. So, for example, if they're breathing into the left side, they might have a deviated septum to the right, and the nasal cavity is compromised on the right side. So early on, you really want to help to treat their development so that they're breathing better.
Beautiful, beautiful, absolutely. And certainly when you're sleeping on your face, you can't breathe on that side. You gotta breathe on the opposite side, and that goes hand in hand, right?
Exactly, there you go.
Yes.
Perfect.
All right. So here we have the tongue tie treatment, which is so easy to do. I know Dr. An does an excellent job here locally for her community, and I think I have other individuals who've taken my course. Who's taken? I think you guys. How's it going? Great, beautiful, beautiful. So you guys can learn this in a weekend and help serve your patients. So we're talking about the cycle of dysfunction, in which it's best to identify these issues early on, when it's just a tongue mobility issue, before it affects the chewing and swallowing. If it's missed, it affects teeth development, jaw development, airway, mouth breathing, poor sleep, and then the body goes into fight or flight, and then they come and see you with hypothyroidism, high blood pressure, fibromyalgia, all these weird kind of symptoms and issues. So I just wanted to give you a little quick introduction on the topic, take any questions, and then we'll talk about the dimensions of tongue tie diagnosis. Anyone want to offer any comments about the importance of tongue ties and why we're all here from the community? I'd love to kind of open the forum for a few minutes. Any comments or questions, or how this affects your care, or something that you learned or found interesting, please feel free. Yes?
How much change can you feel a myofunctional therapist can make to possibly avoid a release?
So sometimes what happens is that if you have like a thick tongue tie like this child does, okay, there's no amount of therapy that's going to resolve it, okay? However, for the posterior tongue ties, okay, the problem is that the fascia is adhering to the muscle. And in those cases, absolutely, myofunctional therapy, body work with the torticollis, okay, will pull the fascia away. It comes out of the genioglossus muscle and the tongue goes up without any surgery at all. And occupational therapy, right, affects the mouth. Oral motor therapy affects the mouth. And there's now investigations on things like Babylase, which is 1068 nanometer. It basically like heats the tongue, and they do different exercises and movements, and the fascia warms up, and then you move the tongue and you stimulate the swallowing reflex. And as you heat it and they're swallowing, the fascia pulls down and the tongue goes up non-surgically. Okay, so we're also learning to kind of identify what cases could be used. Dr. An, you're nodding. Do you have some experience with Babylase, or just you're inspired? Or?
No, I'm interested in learning more about it.
Okay, yeah. So
He has that wavelength in his office.
if you have it, it's fantastic. It's very safe to use. It's very safe to use. It's not only about shining it though, okay? You have to shine it and then stimulate the reflexes, all right? So in these children who have the gag and their shoulders and everything is up, okay? If you just kind of like don't move your arm for a week, a month, 2 months, right? You're gonna get a tight shoulder, right? We had a stretching session yesterday where you taught us how to stretch, and it opened us up immediately, right? So the idea there is that you're heating it up first, and then you're doing specific stretches in the right way. And the way that they elicit those stretches are based on oral motor reflexes. Children under 2, you tap in the right place, and it automatically goes up, reflexive. So you heat it up, and then you do some reflexing to get the tongue moving in the right way, and the right fascia pulls down and the muscles pull up and out. Does that make sense?
Yeah, I did take an in-office course with Dr. Nordstrom.
Oh, he's the man. Yeah.
And so that was very fascinating.
Great. So tell us a little bit about what you learned, it's not just about the light, right? It's
We weren't doing infants. I was like one of the patients that can experience it, and for me, I just remember experiencing pain. I didn't know where it came from. I don't know if I slept wrong that day. Couldn't even concentrate. But once he worked on me, I just remember that pain going away.
Amazing.
And feeling this relaxation like I've never
Um,
felt.
amazing.
So maybe there's something to this. So I did want to look more into
Yes. So the laser is one way, a more sustainable, because in this functional sleep breathing, we're trying to make this accessible to everyone, everywhere in the world. And the truth is that these lasers are not like that affordable, not accessible to everyone, and it's time consuming and expensive. So we also recognize that you can teach patients certain stretches to do, and occupational therapy, and there's different ways of separating the fascia from the muscle, right? And that's the end point that we're looking for. Does that answer your question?
Yes.
Good. Other questions, comments?
Yes, but
Other questions, comments? Yes, please.
I don't want to.
No, this is good.
I want to loop back to bruxism
Sure.
as a compensation for compromise. Give me I have an elevator speech.
Sure, go for it.
30-second
Go.
video.
I want to hear it.
Well, I want to hear yours because I don't want to embarrass myself to tell you what mine is. I'll get it right.
So I love to come to these events genuinely because I learn from you guys. Okay. Anything that I've learned, I didn't learn at Harvard. I didn't learn at Stanford. Okay. Anything that I'm lecturing here, I learned from a conference from one of you guys. Okay. Early on from Dr. Cruz, by Dr. On's sharing, by Dr. Belfort, by Dr. Adams, and really members of the community who go to CEs and they teach me, hey, I learned this, and that's how I've come to learn what I've done.
Well,
So,
my understanding
please.
is that bruxism, there's an activation of muscle groups that help enlarge and at least slightly increase the volume of the oropharynx while one is sleeping.
Yeah. So
Does anyone want to comment on that?
yeah. So you're activating the autonomic nervous system, right? So there's a threat, and the body's immediate threat is to kind of withdraw, clench, get ready to run, to fight, so your heart rate goes up, of course your airway opens, your jaw comes forward, you're positioning for whatever that threat is, and that's sympathetically mediated. So yes, there's a lot of downstreams, and opening the airway is one of those effects. Ultimately, it comes down to a stress on the body, and something's not right. As you're relaxing, the airway's closing, and you get that stress response. And the clenching and grinding is one manifestation in addition to increased heart rate and decreased heart rate variability, which you see with increase in sympathetic tone, and you're measuring those on the sleep image or the watch pat. So this is the manifestation that we're seeing. Yes, please.
Just simply, when you clench, you contract the glossus, which is the largest muscle in the tongue, and it moves away from the posterior pharynx.
Absolutely beautiful.
All right, so that's a fancier way of saying what I.
Yeah, no, hey, excellent. Other comments? All right. From the community, occupational therapist, do you try to call this? What are your thoughts on this?
So I'll just say with the myofunctional therapy component, whether kind of what you were saying, like, is there a way to avoid the release? And with the posterior tongue tag, we kind of see that by doing the therapy, whether they end up needing a release or not, say they do, it makes the frenulum appear more easily so that the procedure can be more effective. Like, I just observed a procedure the other day, and before the baby did therapy, like, you couldn't even get the tongue up and see a frenulum. So we knew the baby was tongue-tied, but where's the frenulum? What are you going to release? So we get her ready, the tongue goes up, you see that white band, and then as she tenses up and starts to cry, you literally see it disappear. So the point of the therapy before the myofunctional therapy is to get those muscles and the fascia to relax so that the frenulum is visible and it can actually be released more successfully.
Absolutely. I've had the same observation, and I see nodding around the room. So
Yeah,
wholeheartedly
it was
agree.
there, and then it just
Wholeheartedly agree. Wholeheartedly
and then
agree.
what do you
Yeah.
release?
Yes, please.
So the latest research
Yeah.
supposedly is bruxing, nighttime bruxing, is a neurotransmitter issue with GABA. And so you technically can never eliminate that nighttime bruxing, because if you eliminate nighttime bruxing, you eliminate sleep. And so there's a GABA neurotransmitter control to that. So I just found that kind of.
That's very interesting.
So
That's
it's
very
sort of
interesting.
gone wild,
Yeah.
in a sense.
So GABA kind of controls those respiratory muscles to open up these airways, so to speak. And so that's a tone or a signal sent
Yeah.
to tell those muscles, hey, Jack, we gotta get some air. We gotta keep this thing going.
Right.
So and it's sleep involved too. Exactly.
Good. Comments? You said you're a nurse in the community? What's your background?
I GI. I'm in
GI, and then is it okay? What any perspectives so far? Any comments to share?
I am just taking all of this in.
Amazing.
I wish I would have known this with my children.
Awesome.
Because they follow a lot into these categories.
Excellent. Any last comments before we move on? Good. All right. So let's take a look at the 5 dimensions of tongue-tie diagnosis. The first one was developed in 1999 by Larry Kotlow. Larry Kotlow did an amazing thing. He was the first person to come up with a grading scale for tongue ties. We salute him. We admire him. Yet, this is just the first dimension. This is just the first study on how to diagnose tongue ties, not the last one. This was based on sticking out your tongue. Can you stick out your tongue 16 millimeters? And what they do here is they measure what's called the free tongue length, the tip of the tongue to the insertion of the frenum. Is this more or less than 16 millimeters? And it really looks at just very anterior tip of the tongue mobility. This was developed in 1999 and validated in ages 18 months to 14 years. For under 18 months, we have the Carrillo's classification. Above 14 years, this has not been validated, all right? So what comes to pass is that you have cases like this, which are certainly tongue-tied, yet cases like this where they go to the pediatrician and they can stick out their tongue, there's no tongue-tie. I'm a medical doctor. I went to all these schools. Look at this, okay? Can stick out the tongue. There's no tongue-tie, all right? Yet, you're using the definitions that were developed in 1999, and since that time, we have progressed with our research. We published on this in 2017 and again in 2021, and we're going to publish again in a couple years as I'm collecting data on the other dimensions of tongue-tie diagnosis. So we're not saying that it's not important. Of course it's important to stick out your tongue. But that's just one thing we're looking for. You guys with me here? And so we have patients like this one who can certainly stick out their tongue. They're told they don't have a tongue tie, no problems. But even though he can stick out his tongue, can he lift up the front of the tongue? Can he lift up the back of the tongue, which you need for good nasal breathing? And if you have a frenum restriction like this that's holding down the back of the tongue, this person's going to be a mouth breather. When they're on CPAP, the air is going to come in the nose and out their mouth. Yet, if we recognize that it's a good start, but we have to go a little bit deeper in terms of how we classify and what we want for our tongue mobility, then we're able to address these tongue ties, get the back of the tongue up, improve his CPAP, decrease his sleep apnea. In 2017, we validated Irene Marqueson's tongue range of motion ratio for anterior tongue mobility. This is determining, can you lift up the front of the tongue? In 2021, we validated lingual palatal suction. Can you lift up the back of the tongue? And really, we want to focus particularly on lifting up the back of the tongue when it comes to sleep and breathing issues, because this is what mitigates which facilitates the jaw growth and development, sleep and breathing function. In the tongue range of motion ratio, we take a measurement of the comfortable mouth opening, and then we ask the patient to lift up the front of the tongue to the papilla. That's an assessment of anterior tongue mobility. And then for the lingual palatal suction, we do the same thing while they're holding the tongue firmly against the palate, the front and back of the tongue. The lingual palatal suction sometimes takes training and can be improved with myofunctional therapy, occupational therapy, physical therapy, and just simple training. In addition, the anterior tongue mobility often also improves with therapy. You do get some stretching, tearing, and release of the tongue function. If they cannot lift their tongue any more than 50%, okay? If they cannot suction up their tongue any more than 30%, that's a red line, okay? That is for sure tongue-tied, no questions, no ifs, ands, or buts. However, there's another category of grade 2 where there still might be an issue, okay? And maybe there is. And there's the grade 1s where maybe there's an issue, but probably there's something else going on, okay? So this grading scale does not tell you if there is a problem, it tells you the likelihood that there's a tongue tie issue. Definitely, 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 definitely. Maybe, probably not. Okay? And for the maybe category, you go to the next definition. Okay? So just because they can lift their tongue up, you check this one. Just because they can do this, you go to the next definition. Does that make sense? So you're ruling in, not ruling out the tongue tie with these mechanisms. Again, you guys all agree that these are tongue tied, right? Yet this is also restricted. This is a posterior tongue tie, as we'll learn to evaluate in just a second. Yes?
Well, when I'm thinking, since the actual tongue tie is created by a lack of apoptosis as we develop, it's a developmental issue. I was wondering, I mean, this is just off the cuff, maybe there's a way to stimulate the genetics, the DNA.
So,
at a certain age.
sometimes a lot of premature birth, right? 36, 37 weeks. You're not going to the full term. And then parents are scheduling their C-sections because it's more convenient, or they're trying to get their babies in before the school deadline.
Right.
All right?
Do that?
Yeah. My wife's friends do that.
Oh.
All right? Because it's so important. Because if you're not born before like August 30th, September 1st, is that what it is? But then for preschool, it's different. It's in April 30th. Okay.
It's not February.
It's not February. So whatever it is, right?
What is wrong with that?
So there's February, August, and then in April. You gotta get in before April to make it to the nursery.
Yeah.
Something like that.
All the name
So-
is saving, $4 grand.
Huh?
skipping
It's like, what's the point? Like, I'm not gonna, it's like, I tried so hard. I want to make sure it's before okay. 3 weeks premature, 2 weeks premature. What's that? Sleep at night. It's convenient. You can plan the baby naming or the ceremony. You have it's convenient. You know what I mean? It's got to be convenient for everyone. Otherwise, it's going to be a problem, right? What if you're working on the day? You can't have that. Let's schedule it. So I'm not doing surgery on the day the baby's born, right? That's the society that we're in. Because you have to plan your maternity leave. You have to give advance notice. What if you're overdue and don't have your maternity leave? Wow.
What's that vacation?
Huh? Yeah. Yeah. Yes, please.
Are there actually studies that show correlation between
Premature birth and tongue tie, yeah, for sure, 100%. Yeah, 100%. Yeah. So that's one aspect. The other is lack of mobility in children who have low tone, who don't move around a lot. It adheres, and then you get fascia restrictions that OTs can help us with. Yeah. So multifactorial. All right, so we talked about this. So this is tongue-tied, right? Both of these are tongue-tied. I don't have to beat this around the bush. These are not tongue-tied, right? We do comfortable mouth opening. We don't do, okay. If you did this, everyone would be tongue-tied, right? Because you're never gonna get your tongue up all the way. It's impossible, all right? So while I'm telling you we're comparing the tongue to the mouth opening, I'll also tell you that these are limited. Because if you have trismus, it'll be 100% tongue mobility all the time, right? It opens the full degree. And if you have like hyperlaxity or Ehlers-Danlos syndrome, then you'll always be tongue-tied because you'll never get the tongue up, right? So when we publish this, we put an asterisk that other clinical factors should be considered. You guys see that? So this is one thing you look at, but if the mouth opening is not very much or it's too much, then this is not going to work, and that's okay, right? And so you can look at the individual measurements. You can look at just the tongue itself. You want the tongue to go up 28 millimeters and the LPS to go 22 millimeters, and you can kind of make an assessment. Okay, we can use things like Easy Prop styrofoam bite blocks that we use, and so if you put it on this setting, and the tongue goes up more than 28 millimeters. You're in good clinical range. You're going to be in the 2A range, okay? If the tip of the tongue is getting up more than one bite block, if it goes up when the second stage, okay? So you put the second stage on, and then you do the suction hold, then you're going to be above in the 2A range. So you're probably okay. So in clinical practice, we're no longer telling people to sit there and measure, right? If you're seeing the hygienist and all that, we're just saying, hey, have a bite block ready, put the bite block in the mouth, on the biggest setting, lift up the tongue, put the bite block on the middle side, suction up the tongue. That's it, 10-second assessment. If they can do it, they're probably okay, all right? Not definitely okay. These are just routine patients that you're seeing in and out. This is not a thorough assessment. The thorough assessment's gonna come in a second. You see question marks? Okay, all your patients, all the hygienists, here's a bite block. Open up your mouth, stick out your tongue, lift up your tongue, suction up your tongue, move on. 15 seconds, okay? It's a screening. It's a screening, all right? And if you can do it, you're probably okay. If you want to go more, then you have to learn to look for the compensations. Yes, you can lift up your tongue with the bite block, but you're lifting up the floor of the mouth. You guys see that there? Okay? And you're compensating by pulling all this up. So this is not natural and resting. And so look at this lady. Yes, she can lift up her tongue, but at what expense? What are you noticing? She's doing jaw deviation, straight, floor of mouth, protruding forward. Yes, so neck engagement, all these different compensations, okay? Floor of mouth elevation, neck engagement, tongue-jaw dependency. All right, so we try to do a study like which one of these factors is the most reliable, what can we do, what can we teach people to do? Yes?
So what I suggest is a study on the airway relation after tongue tie release, because when the tongue is limited, actually, what happens is the tendency to breathe out of just one side. So when you free up the tongue, that allows the mandible to align better, and you actually get more breathing through the airway.
I believe it.
It's directly related to breathing.
I absolutely believe it, because you're decreasing the respiratory effort required, and you're able to get a much full deep breath. Also, when your shoulders are not forward, they're back, you're able to get that diaphragmatic breathing, and absolutely we see that in our patients. So to take it to the fourth dimension, we have now collected data on over 300 data points on the floor of mouth hold maneuver. This is 99% sensitive and specific for posterior tongue tie. What you do is you put one gloved finger on the sublingual caruncle here on the Wharton's duct, okay? And you ask the patient to lift up their tongue. The posterior tongue tie will show itself, okay? And in our research, we tried all the different kind of things, like 15 different things. This one, it was 99% across the board, okay? That if they had a posterior tongue tie, it would show up. And then once you treated it and the patient was better, it was no longer there. So this is what we're seeing for the posterior tongue tie. One gloved finger to the floor of mouth, lift up your tongue. So if you're screening your patients, you do the bite block mobility assessment, see if they need myo. You do the floor of mouth hold test to see, are they going to require surgical intervention potentially to help them get up this back of the tongue. Juan Moon has shown that patients with this floor of mouth hold maneuver, okay, where they have cupping of the posterior tongue, is directly consistent with transverse maxillary deficiency. Amazing, right? The back of the tongue isn't getting up, they're not chewing, they're not swallowing, they're not breathing, they're not developing. So let me spend a second showing you this maneuver.
You can see that it looks like a grade 2 tongue mobility, but really she's bringing up her entire floor of the mouth. And if we hold her floor of mouth down, where it should be, and ask her to lift up, you can see she can't get it out. She just cannot get up her tongue. You see the dimple right here that reflects the side of the frenulum attachment point.
All right, so that was one example of a case that has it. Let me show you an example of a case that is like normal control, okay? No tongue tie problems.
Discomfort. All right, now lift up your tongue up to the front 2 teeth. Now suction after me. Show me your cave. Excellent. We don't really see any compensations here, but if we want to control for them, we can use this word director. And so go ahead and open up your mouth. And I'm just holding down the floor of the mouth here and noticing that it's not restricting the mobility of the tongue. Very, very good. And show me your cave. Okay, and again, we're seeing it's not lifting up the floor of the mouth in this example.
Okay, so that's an example of normal. And let me show you an example of, this is not tongue-tied, but not able to do it, needs myofunctional therapy, okay?
Hi, Rose. Welcome. Welcome. We're going to go teach you tongue mobility, okay?
All right.
So just go ahead and open up your mouth to me without any discomfort. Very good. Lift up your tongue. Lift up the front of your tongue. Excellent. Do a
So
suction
she's
hold.
still using the neck and the floor of the mouth.
Drop down the tongue and put one finger on the floor of the mouth here. Lift up your tongue. Lift it up.
Okay.
Very, very, very good. Now do the suction hold. Excellent.
Okay,
That's
so
okay.
this
So we
person
have the
needs
suction hold.
myofunctional,
Very good.
fascia, laser,
Lift up the tongue.
something else.
Great.
Doesn't need to
Lift up
get
the teeth.
the release cut.
Great. Into the suction hold.
Or at least first.
No worries. Needs a little bit of
I
myo.
need some myo.
Okay, so those are the three possibilities with the maneuver. Either it's like perfect, like great, excellent, okay? It's tied and that's it. Or they're struggling a little bit. Just struggling a little bit, therapy, okay? If it's tied, therapy and release. If it's normal, move on to something else. Questions? Yeah, go ahead, please.
This is a recent video, right?
This is new material. Ask me a question.
Oh, it's not. I just noticed you have the same shirt in the video.
Oh, man. Wow. Amazing. Wow. Let me tell you. Yeah. So, Wow. I'm wearing the same outfit. You got me. No, this is actually a little bit old. Yeah, I don't know. What's that? My only shirt. I only wear 2 shirts. This is one of them, right? Wow, how about that? I didn't even notice that. What was I wearing in Jen's video? Is the same shirt again here? I have 1 shirt? No, I was wearing something different. Okay. Phew. I need to go shopping, huh? All right. That's my lucky shirt, all right? All right, take a look at this gentleman. You can see he has the frenulum restriction. He's getting his tongue up, but you're seeing how much strain he has. Okay, tied, right? Okay, so here's what he looks like before and after the procedure. Here's what his CT looked like. Note the lights are on here, but this is the tongue, and it dimples down here and back up. It's tied there. You see it on the CT? Okay, and then here is the tongue fully up 3 days after the procedure. Isn't that amazing? It's amazing, right? Yeah, you guys saw it, right? If you guys saw it, it's okay. You also have the slides and things like that. All right, so it looks just like this, where the back of the tongue is down. That one was dimpling actually, and this is up. Just keep back up, it's okay. There's no worry, yeah. All right, so posterior tongue tie. Where is the posterior tongue tie? Some people, we're thinking the posterior tongue tie is here, right? Get this back of the tongue up. But in actuality, the posterior tongue tie is actually the posterior aspect of the anterior 2/3 of the tongue. So a posterior tongue tie is really a middle tongue tie. It's the middle of the tongue that's depressed, not the back of the tongue. You guys follow me here? And so it's the posterior part of the anterior 2/3 of the tongue. And this is the posterior 1/3. This is always going to be down, okay? It's stuck to your hyoid. You're not going to get your hyoid to the palate, except when you're swallowing. It goes up when you're swallowing, and then it comes back down, right? But at rest, it's going to be down, the back part of the tongue. But the body of the tongue, the anterior 2/3 is what you want up there. Does that make sense? And the posterior tongue tie happens in this, this body of the tongue, as opposed to the apex of the tongue, which is the tongue tie. Yes, question.
What is the innovation of that part of it?
It's like you have a hypoglossal nerve for motor, and then you have a lingual nerve for sensation and taste for the anterior, and then I think the posterior it would be glossopharyngeal 9 for taste and
So
sensation.
when you get your tongue up, you're activating glossopharyngeal. That's innervated by never mind.
Yeah, so sensation and taste and sensation is like 7 and 9, and then motor movement is 12, and then like pain sensation. I don't know. Is trigeminal? No, trigeminal doesn't go to it rides on. What's that? Trigeminal is everything, right? So the lingual nerve branches, but the root of it comes from 7. So lingual nerve goes 7 onto 5 into the tongue. Yes, was that right? Or someone wants to update me?
I don't have this memorized.
What's that? All right. So in this paper, we published 2021. We're defining what is a posterior tongue tie, okay? And we're saying that the posterior tongue tie is the posterior 2/3 body of the tongue, okay? That's what we're talking about, not the tongue tip and apex, okay? So you have the anterior tongue and the posterior tongue. Of the anterior tongue, the posterior tongue ties are in the posterior 2/3 aspect of that. So this is, let's go back. This is the tongue apex. All of this is posterior tongue tie category. This is base of tongue. All right, naturally optimal, doing good, right? The next category is tension, all right? And this is something that's hard to quantify or measure, but you can see this is tense because it's pulling down the tongue here. Do you see that? See how the sides are up, but the middle is being anchored down, and here there's no anchoring or pulling up of the floor of the mouth. That's the 5th dimension of tongue tie assessment. All right, now that we're experts, all right, would you like to look at some case studies together and grade these individuals, okay? 39-year-old, facial pain, bruxism, neck and shoulder tension, all right? Barely able to get up the tongue, 32%, or less than 50% is the cutoff. Barely able to suction the tongue, directly related to this freedom restriction. Tongue tie or no tongue tie? Yeah, you guys agree, right? Okay, so, let's take a closer look. So this is someone that you'll pick up in your routine dental screenings. Don't miss this, right?
Okay.
All right, so it just is tongue-tied, okay? Easy, any questions there? All right, so here he is afterwards. All right, and our end point is you push your finger down and it's getting up. Go. Okay. All right, not tongue-tied, okay? In order for me to keep him in my tongue-tie series as a positive outcome, 2 months later, floor of mouth hold, he should still be able to get it up. Then I'll do a sleep study and say, hey, let's see what your sleep looks like. If they scar down, if they're still not able to get it up, then I'll be the first one to tell you the sleep study is not going to change. Okay, so it's not only about doing the procedure, it's about getting to that endpoint of high tongue posture, no dipping. That's what's going to have the effect. Okay? All right, so case study number 2, 12-year-old. All right, okay, so this is someone that if you're doing routine, okay, you're going to miss this. All right, and that's okay because this is like above the threshold. But if the patient's coming to you now with difficulty falling asleep, malocclusion, oral habits, okay, now you're going to look a little bit closer at it, right? So when you take a little bit closer, this part of the tongue is coming down. It looks a little tight, okay? You're still not sure, is it tied? Is it not tied? All right? It's looking more like it's tongue-tied. Yeah, go ahead, say what you see.
Maxilla is tilted.
Maxilla is tilted. You're seeing some issues. He's not biting, right? When you have papillons, like from my perspective, if you're actually chewing there.
Yeah, it's mammalians.
Mammalians? Yeah. Wouldn't you guys agree that he's not, like, right? When they're not chewing on there, if they were chewing, then the mammalians would kind of absorb away?
Lower teeth are not occluding with it.
Not occluding, right? There's something wrong, right? All right. Looking more tongue-tied, no?
Do suction hold. Good. Drop your tongue down. Open up your mouth. Lift up your tongue.
Boom. Okay, so that tells the story. And this is going to be a combination of the therapy and the release, okay? Because you can see the tongue is still a little bit weak. So we do the procedure. Here it is, much, much better, okay? And let's take a look. Much better. Yes, please.
Do those dissolve?
Dissolve.
Immediate post-op.
Mediate post-op, mediate post-op. Yeah. When we do the course, I show you what it looks like at 2 months, a week, 2 months, a year later. I have like 5-year follow-up. I think 6 years follow-up is the most that I have, and we show it. And it after a while, it looks totally pink, and all this is consistent. But since this is beginning, I just wanted to kind of keep it as consistent as possible, show you immediate post-op so that you can see the immediate effects. Yes?
And do they have to be careful with that, correct, so they don't pop their...
Yeah, so for the first 3 days, we don't want them sticking their tongue over their teeth so they can rip it, and we don't want overly aggressive. We don't want overly aggressive, so just light exercise for the first 3, 4, 5 days, and then...
Not a big...
Because you don't want to pull it, because it's not going to contract the first 3 days, as long as sutures are there. Contraction happens 3 to 7 days. Oh, got it. So maybe a little too aggressive, or the sutures weren't tied appropriately, or something like that. Okay. If you don't square your knots, they can pop out too. So you have to throw a good square knot. Yes.
On these younger patients, do you ever do tongue tie release and tonsillectomy?
Absolutely. And I could show you a video of that if you're interested to see. We're doing the tongue tie release and the tonsillectomy. Absolutely. Yeah.
Are tonsillectomies effective in adults too?
Yes, absolutely. In the right patient, absolutely. Yeah, absolutely. Yes. No. I want you.
So you said that it was the finger and the floor of the mouth is like 98%.
Yeah.
Sensitive. How do you validate that? How do you know what's the gold standard of knowing whether they have it?
That's a good point, and that's why I want to do more research with you because you're critical in that way. What we're doing is basing it on what came before us. Okay, so we're basing it on TRMR, TIP, TRMR, LPS, and compensations assessed by the therapist. So the therapist has worked it up according to their complex algorithm that there's a posterior tongue tie here. Okay, and then we do the floor of mouth, it goes, right? And then I'll do the surgical release until there's no more, and then we'll send it back to the therapist. They'll do their whole complex like measurements, TRMR, bite block, assessment, and they'll say it's better, and then we'll say, okay, we're on the same page. Yeah, so but it is a little bit of circular reasoning. I agree with you, okay? You saw it, okay? Because you can't create something out of thin air, right? Because in a way, we're using the diagnostic criteria to validate it. I don't disagree with you. So it's not going to go to like laryngoscope journal. It's going to go to like International Orphish Melalgia. I'm just being transparent with you.
Cool.
Yeah. So it's not high level. If there was a way, let's do it. But have you guys tried floor of mouth hold? And what's your experience? Pretty reliable, right?
Very definitive.
Yeah, it's very definitive.
I was
Yeah.
wondering if there's like an independently way.
So I'm just telling you on the video too. Okay,
Yeah.
We're gonna publish it. I'm not gonna send it to a premier journal because it doesn't have that robust of a science because of what you said. But it is what it is, and we got to move on with life. Okay, because clinically it works, and it works in our institute, and that's what counts. In our institute, this can like predict what the therapist is gonna say. So there's good internal validity to using this. There's not good external validity. Meanwhile, Juan Moon has showed that the floor of mouth hold separately outside of our group correlates with maxillary deficiency, right? And then when you publish something independent of us, boom, that's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Someone does a review, and now it's level 1. So I'm not saying that this next study that I do is going to be level 1. It's going to be level 4, 3, but that's where you start, all right? That's the best we can do. Is that okay? Yeah, but so you're saying the science isn't strong. You got to start somewhere, right? What are your thoughts on that? You just got to start somewhere, right? You can't. We're not doing randomized controlled trials. It's not blinded, right? It's me doing it, okay? And
So there's no way like an MRI or like some other imaging tool to be able to tell?
we do CTs and tongue posture changes.
Okay.
So we have that too. But a lot of people don't want to do CT twice. But every time I've done it, it's changed.
Right.
Like I've had like 10 of those. And I'll show you my course. I show them like boom, tongue down, tongue up. CT shows it. You could do ultrasound, but ultrasound's too subjective. CT, it's how you take the CT, as I'll talk to you. But I'm really excited to do some research with you. Yeah. And Dr. An, I know we're going to do some research projects together as well. Okay, so let's look at more cases. All right. This one, 34-year-old neck and shoulder tension, TMJ bruxing. All right. These are the cases that we get as affiliates, right? That, am I tongue-tied? Am I not? Look at how much she's lifting her tongue. Are you really going to call this patient a tongue-tied patient? Okay. Yet we do the floor of mouth hold.
Lift up your tongue, drop your tongue down. Open big, and lift up your tongue. Good. Lift up your hold. Very good. Okay. Now relax your tongue down. And lift up your tongue.
Okay.
Good. Relax your tongue down and lift up your tongue.
So this is a little bit of a soft call. Okay. And that's okay. But she's suffering. So if you saw her routinely, I would leave it, okay? But if she's coming third, fourth, my functional assessment, my functional therapist saying I'm tongue-tied, like let's get the ball going, okay, we release you. So do you guys see how it aids in the clinical diagnosis, but it's not like, it's not all or none, all right? So we release her, her neck opens up, her shoulder opens up, her breathing opens up, successful outcome. She immediately felt the fascia, the chest. And it turns out that these patients who compensate the most often benefit the most from these procedures too. All right, so is it important? Can tongue tie cause low tongue posture? Yes, tongue tie can cause low tongue posture, right? Is tongue tie the only cause of low tongue posture? No. No, okay? This patient, are we okay with time? About 30 minutes more, is that okay? Okay. We can take a break if you guys want, but let's just do this slide and then. So this patient, is he tongue-tied? Not on earth, right? There's no way. I mean, it's got magnificent tongue mobility. This is Kachari Mudra. There's some patients who come seek me out because if you can get your tongue back there, you achieve like unlimited enlightenment and like clarity of thought and like it's the ultimate state of being. Yeah, it's called Kachari Mudra. Yeah. But he's disappointed because he can't get the back of the tongue up. This is a patient with tongue overflow. Okay. So tongue overflow means lack of tongue space. When the tongue is overflowing on the sides here, there's no way that you're going to get the back of the tongue up because it hits the sides and it doesn't get up because the palate's too high. So this is a tongue space issue. Okay. Tongue tie, tongue tone, and tongue space. Okay. You need all three to have a good outcome because inadequate tongue space is also a cause of low tongue posture. We need to make sure that our patient is able to breathe through their nose, prepare them with therapy, release the frenulum, and then restore, rehabilitate, and more. All right, I'm just going to pause 1 second, okay? I have about 30 minutes more. I don't know what the schedule is. You want to take a 5-minute break and come back? Or let's do that. Let's take a 5-minute break, 10-minute break, and then come back. Yeah. What else do you have on the schedule? Or it's okay? Okay, great. Okay, so we'll take a 5-10.
I think there's somebody leaving about 4
Okay, or maybe wait a couple minutes or what? Or just you can come in? Okay, I'm just gonna go, okay? Okay, yeah. I wanna tell you guys about our protocol now. Our protocol was published in 2019. We did 350 cases, interdisciplinary, and we showed for the first time that combining myofunctional therapy with this procedure can be safe and effective for the treatment of mouth breathing, muscle tension, snoring, and clenching with minor complications. The protocol begins with myofunctional therapy until they're able to adequately achieve a suction hold and movements of the tongue without compensation. The procedure is under local anesthesia while they're wide awake. We put topical anesthetic, small injection of that area, and then use a combination of scissors and or laser to complete the release. Then they have to do some postoperative myofunctional therapy for a couple months out, and this is the final result. This is interactive.
I noticed 93% clenching.
Yeah.
So how do you measure that?
It was a self-report.
Okay.
Yeah.
Subjective. Okay.
Subjective. It's a case series. It's not. Yeah. Okay. It's not high level.
Cool. Okay.
Yeah. It's like, are you better? Yeah. Is it better? Yes or no? And then ultimately, that's what you want though for your patients, right? And so I recognize that it's subjective, but patients had this and they were happy and they were satisfied, right? We teach this technique in my course, both laser and scissors approach. Dr. Ahn, which one are you using now? Combination approach? Combination is the way to go, okay? You have multiple tools in your toolbox. There's different cases and scenarios where you need each one. They both have the benefits. The laser, you get less bleeding. The scissors, you get better dissection and surgical, but it requires a little more surgical skill. I really advocate for placement of sutures where possible. Sometimes when it's not possible, keep the wound small, periacral glue. Our procedure is distinct because it's the first time that we've shown that it's safe to release the muscle. There's no other study that's shown that it would be safe and effective to release the genioglossus muscle. Prior studies were focused on mucosa and fascia, but our approach in 50% of cases does include fibers of the genioglossus muscle when they are interfering with tongue mobility. And I'll show you an example of that, okay? So based on the work of Nikki Mills, as well as our observations, we have learned that sometimes the genioglossus muscle is involved in frenum restrictions, okay? Previously, it was believed that either there was no tongue tie, this is the mucosa and the fascia of the floor of mouth, or there was a tongue tie composed of mucosa and fascia. Based on the work of Nikki Mills, as well as through our research, we're seeing that some tongue ties are just mucosa. These are gonna be easy. You snip it with the scissors, it's over, it's fine, okay? Sometimes it includes mucosa and fascia. If it includes the fascia, you really, really do not wanna use diode or electrocautery, because the electrocautery will dry up all the fascia down here and cause tightening around the genioglossus muscle. So it's not advocated to do that, all right? Other times it includes, so this you could also do with scissors, no problem, okay? Because there's no major blood vessels here. Other times there's mucosa, fascia, and genioglossus muscle. Two approaches. One is to come down here and just laser through everything. A better approach may be to go layer by layer by layer to take care of this muscle fiber. Once the fascia around the genioglossus muscle is released, you will see the genioglossus muscle drop back down into the ventral surface of the tongue. Okay, I'm going to show you this example right now. So let's take it back here 1 second. So we're about to see this case, okay? Note that this is the genioglossus muscle, and note that it is protruding and tethered by the fascia tissue. We start with myofunctional therapy, we start with body work, you could try different lasers, but ultimately the fascia is investing into these genioglossus muscles and causing dysfunction. So we release it, and once we release it, you have a whole body release. Let's watch. This is the scissors approach. All right, so now you see that there's still fascia around that genioglossus muscle.
So there's a restriction, okay? You can see it right here. There's a restriction.
Boom.
Close.
She feels light in her chest, breathing deeper, better diaphragm function, shoulders go back a lot, doing so much better, okay? So here she was before and after the release. Here she is post-op day 1. Here she is 2 months post-op, okay? What a great release. I'm showing you this to distinguish from the standard of care. The standard of care just kind of cuts through the tongue, all right? And it's unfortunate that I get messages like this case in which this patient went to Kaiser and said, I have a tongue tie. First they said she didn't have a tongue tie. Then they just kind of cut through into the body of the tongue, totally missed the frenulum. No aftercare, no sutures, poor thing. That's all they did. And then she's in pain, dysfunction. They said she's fine.
How many weeks post-op is this?
This is 5-10 days.
Speaking, yawning, hurts it.
No, before you got released or right now?
No, right now. So
Right.
I had the surgery done 10 days ago.
Got it.
The hole never closed and I got a white lump above it.
Yeah.
Went to the emergency room, they told me nothing. They were like, oh, you're fine.
So one of our colleagues thinking you were so happy with it.
Yes, definitely. Yeah, thank you.
All right, so we go ahead and we release her according to the functional frenuloplasty protocol that you guys can learn in like a few-day course. Okay.
Oh, God.
You notice the difference?
Yeah, I can switch on my tongue.
Nice. Lift it up. Try not ask you to take it out too much in the recovery period.
Right.
You don't try to sleep. Okay, take
Yeah,
one more.
but it's gonna be, there's so much time.
Better, right? Let's get in there, take a closer look in there. Put the mirror down for me, yeah. Lift up your tongue, good. All the way up, and sit up.
Okay. So in the course we good, and these are removable PTFE sutures. Okay. Really good. Good. Really. 4.0 PTFE in this case. Okay, because it was really inflamed, and the chromic doesn't hold well in inflamed tissue. Okay, so we did PTFE removable suture. Okay, so there's a lot of nuance. The point of this is to show you a lot of nuances to doing these on a very, very high quality, high level. And we're happy to, teach people all over the world. We have 2,500 ambassadors, as well as almost 50 affiliates, among which Dr. On's office is one of them. So we're so proud of all of our affiliates who take our course, but then they come shadow me, and then I come watch them do 10 cases, and we see their results and make sure that they're reproducing, to our level. It first starts with good patient selection, right? And a part of good patient selection is ensuring adequate tongue space. There are patients like this one who can get worse after frenuloplasty. This is a patient with 4 bicuspid extraction, retraction, class 3, who had an initial tongue tie release, but felt like she was still posteriorly tongue tied, right? I did my procedure. She's no longer posteriorly tongue tied, but her apnea-hypopnea index tripled to now an AHI of 56 events per hour. She had limited tongue space, limited posterior airway space, and was already compensating her posture. We're going to spend the next 15 minutes talking about how to identify patients who may or may not be good candidates in regards to tongue space. Here's another patient who had the procedure, and now she's biting and clenching with the edges of her tongue. So before we do tongue tie procedures now, to avoid this, even though it is a rare occurrence, maybe about 5% of patients have experienced this in my hands, maybe less, we're being more mindful of the tongue space. And this is how we do our functional tongue space analysis. We're validating the functional tongue space classification. We have the patients hold their tongue up in lingual palatal suction, and we're assessing for overflow. If it's within the groove of the maxillary teeth, if it's under it, it's mild. If it's beyond the mid groove, it's moderate. If it's outside the buccal aspect of the teeth, it's considered severe overflow, all right? So how much overflow do you have, all right? Mild to moderate, severe. Yes, it's subjective. Yes, how far forward you bring it, how much therapy you've done will affect it. But a severe is not normal, right? And, mild, okay, you could do the tongue tie release first. Moderate, maybe still do the tongue tie release first. But if it's severe, if there's tongue scalloping, okay, if you do the Friedman tongue position and all you see is tongue, all right, these are not good candidates for the procedure. We've also developed something called the lingual palatal suction palatal flutter sign. The goals of myofunctional therapy are tongue up, lips closed, nasal breathing through the nose. So we say, elicit a snore. Now put your tongue up, close your lips, try to breathe through your nose, and snore. I can't do it. I can't snore with my tongue up. You're going to be a good candidate for myofunctional therapy and tongue tie release. But if you can still flutter, even though tongue up, lips closed, nasal breathing, there are other issues going on. Okay? Elongated palate, tonsils, maxilla, mandible. It's not just the tongue tie and the myofunctional therapy. Get a CT scan, do a further evaluation. Does that make sense? Okay? So if you have overflow, if you have scalloping, you guys all do CTs no matter what, right? Okay, that's great. But if it's like a myofunctional therapist that's wondering, and you have all these signs, they need to really have a tongue space evaluation. In terms of the tongue space evaluation, we have found that patients who have an intermolar width less than 32 millimeters portends very poorly for a good outcome from tongue tie surgery. You might do the tongue tie surgery, get a good outcome, but it's not going to be like perfect, amazing, slam dunk because they're still narrow, all right? Whereas patients who have very wide maxillas tend to do better. It's not all or none. yes, if someone has a severe tongue tie and they're less than 32 millimeters, I would release them, okay? But you must have that discussion of, hey, let's see a CT. You're gonna need to do something with your palate. They have to have process that and then do the tongue tie release. Again, this is not contraindication to doing tongue tie release. This is saying that you have to have that discussion, that tongue space discussion. Make sure they understand it. Otherwise, you clip the tongue tie, they come back. I still have neck and shoulder tension. I'm still clenching and grinding. Go deeper on my tongue. It's not fully released. I can't reach up all the way. I'm still having these problems. So we're trying to mitigate that because the tongue tie is only one aspect of the problem. Does that make sense? So I'm not saying don't do the procedures if they're narrow. I'm saying do it only as an adjunct to other interventions. CPAP, homeoblock, MSC, SARPI, DOME, MMA. There's other things you're gonna need to do. And if the patient can accept that, then yeah, we'll go ahead. Does that make sense? Yes.
It's kind of an interesting side note from my perspective. From a traditional Chinese medicine, which was 2,000-3,000 years ago, they identified scalloped tongue as being associated with specific physiological issues.
Yeah, kidney and liver.
And spleen.
And spleen.
So those are pre-existing that are going to be needed to get resolved regardless of what you.
Absolutely. And the kidney, liver, spleen is often inflammation.
Exactly.
Okay, so if you're seeing this and they're having dysfunction, it's not just the tongue tie. There are other things going on. You have an inflammatory, something's wrong. So do your due diligence, find out. Probably have sleep apnea. That's why they're inflamed all the time. Maybe they're not having a good diet. Maybe they're having too much gluten or dairy or something is up with their GI system that's contributing them to be swollen. And that's the root cause, not the tongue tie. So I'm just trying to keep you guys maintaining a high level of patient satisfaction. And one aspect of that is not only the surgical technique, but also the careful discussion with the patients that, hey, this is one aspect of their problem, it's not the only problem. In measuring the posterior airway space, okay, ideally you want 1 to 1.5 centimeters, but the posterior airway space and volume is heavily dependent on posture. Slightly tilting the head down, slightly tilting it down, slightly tilting it up can magnify the posterior airway space double in this case, okay? It's not a surprise that head posture affects posterior airway space, okay? As well as cross-sectional area and volume. You guys can see that when the patient puts their head up in this MRI, the airway opens up. Do you guys see that? When the head goes down, the airway closes, all right? Moreover, the tongue posture changes, okay? Tongue posture changes can also affect posterior airway space. Our research has shown that a 5-degree change, 5-degree head up or 5-degree down changes the airway space by 25%. 10 degrees up or 10 degrees down, 88% difference in the measurements of the posterior airway space, okay? 5 degrees is 25, okay? 10 degrees, you're 88% different. We have also assessed the effect of things like sitting versus standing, using a chin rest, and things like that. Like Dr. Belfour mentioned, you want to walk into the chin rest, you don't want to extend into it, and you don't want to depress the chin. Both of those can affect your measurements. Bite registration may work well if you're trying to do other cases, but if you're trying to measure the airway, a bite registration is going to alter the tongue position. And what else? And joint position. It's going to give you a different measurement. A sitting study should be compared to a sitting study. A standing study should be compared to a standing study. When you stand, the posture changes. Your head goes back. The airway's longer. When you're sitting, the airway's flatter. Your head is forward, all right? Sitting and standing, whatever you want to do, has to be comparable, all right? So Dr. Koppelson is one of the lead authors on this, and this is going to be published soon. Here are some of the figures from that paper showing that head tilted up versus head neutral does like a 164% increase, okay, in airway volume. Here the head is down and it's showing, here's the down, 59% decrease in airway volume. So our CBCT scan protocol is the same as Dr. Belfour's. We published it in this journal. Natural head position, horizontal visual access, looking at inside the mirror. Close the mouth. If the mouth is open, it changes the airway volume. breathe through the nose, place the teeth together. If the teeth are apart, again, that will change your airway volume. Swallow once, then rest your tongue where it naturally goes. Avoid bite registration and avoid reaching for the chin rest. We have also seen in our research, I don't have the slides here, that when you open the airway with palate expansion, oftentimes the first thing that changes is the posture. The posture goes back. So using the posterior airway measurement as an outcome sometimes doesn't work. I actually ask people, hey, send me your scans after you expand people. I look at the airway measurements and it's not that much bigger. But what does change is the posture. And we can measure the posture with the NBC3 angle and show posture improvements. And this study will allow you to convert those posture improvements into airway space. Does that make sense? Okay, that's why when you pull 4 bicuspids, the airway chain doesn't change because they're compensating by putting their head forward. And when you recreate space, their head goes back because they have to fight for that airway. Questions, comments on this concept? You guys all on board? Yeah, all right. So this is now going to be in the published literature. It's before and after. It's a pretty high level study. The other study wasn't high level. This is before and after CT scan, blinded radiologists by beam readers who did the measurements, totally objective. It's going to go to, I think, Journal of Oral Maxillofacial Surgery. It had really good reviews. It's going to be a really high level study. So look out for that coming this year. Let's take a look and decide if this is going to be a good candidate for the tongue tie release procedure, okay? What do you guys think? Pretty severe tongue tie, right? And the tongue space looks adequate and appropriate. This is about 110, which is the average what it should be, good PVA projection, really good posterior airway space. The tongue is low and there's space for it to go. This is going to be an excellent candidate. I'm going to predict that this patient will have improvements to snoring, sleep, and bruxism. All right. This patient, however, okay, is not going to have a good response to her snoring. She is already as forward head as she can go, 10 degrees. Okay. This patient needs to be palate expanded. When you do palate expander, the first thing that will change is the posture, then the airway. Interesting, huh? Yeah. Let's take a look and look at more CBCT scans and see what they teach us about myofunctional therapy and tongue tie release. Here is a patient who had an amazing response from her therapy, okay, and her tongue tie release procedure. Note, before her tongue was right in the middle of her teeth, low tongue posture, snoring because the palate's not supported, mouth breathing. Why mouth breathing? The air is coming in and out of the mouth. We do the procedure, the release, the tongue is now really nice, high, up in the roof of the mouth. She had an excellent outcome, no longer grinding, sleeping better, better nasal breathing. You guys with me? Note that even though she had a great outcome, the tip of her tongue is still between her teeth. Her tip of the tongue is not on the palate, and that's okay. And that's okay. All right? So these principles that we're teaching have to fit for the patient. This patient is trying to put his tongue on the spot. But this is not a resting position, and trying to do this all the time is going to contribute to headaches for the patient. All right? This patient is better off keeping the tongue low, all right? Unless you're going to do jaw surgery or something to fix the tongue space issue. The tongue has to fit that space. And in this case, it's dysfunctional. But tongue tie release is not the answer. Similarly, tongue tie release is not the answer in this case, in which there's just no room in the mouth for the tongue. You guys see that here? There's no way you're going to get the tongue up that way into that high arch palate. It's just not going to go. Questions, comments, please feel free. How about this case? Is this a good case for tongue tie surgery? Patients walking around like this all the time, even though the head is as forward as it can go, 3 millimeter airway. I'm going to say no, because if you release this tongue tie, it's just going to fall back and block the airway. When you have forward head posture, the back of the tongue naturally comes down. Not because of tongue tie, because of forward head posture, limited airway space. Let's take a look at another case. This gentleman was referred by the dentist for myofunctional therapy in preparation to close the bite with aligner therapy, okay? The myofunctional therapist recommended therapy for tongue thrust. In her evaluation, the therapist identified a tongue tie. And yes, that is a tongue tie. It's pretty tight, okay? However, you guys think we should do a CT on this patient or just jump to the surgery?
So, run away.
Run away. You're right. Okay? Because look at this. Okay? He has to have an open bite. The open bite is helping him. It's adaptive. If you close his bite with the liner therapy, you will worsen his sleep apnea. In this case, if you refer this patient to me, I would say keep the open bite. Keep the open bite. Maybe you want to wear some retainers or something so you don't get paralysis. Either you keep the open bite or you have jaw surgery and weight loss and all that. Maybe add CPAP, not releasing your tongue tie. It's not going to do anything for you. Let's have a discussion. Because these are concepts that are like different than what you expect, right?
Are there any instances where myofunctional therapy would be contraindicated? We're talking about tongue tie releases, but
Not contraindicated because you're not going to harm the patient, but you have to have reasonable expectations. You're not going to keep this patient in therapy listen, you're not going to improve this guy's tongue thrust with myofunctional therapy. Impossible. Okay? So if you're saying, come do therapy with me, I'm going to fix your tongue thrust, all right, it's not going to work. But if you're like, come do myofunctional therapy so we can work on your breathing, so we can work on your posture, so we can work on your chewing, so we can make the CPAP more effective, okay, or let's get you ready for jaw surgery, yeah, do the therapy. But don't think you're not going to be successful. Because you do all the therapy you want, he'll keep his tongue at any night, and then he'll fall asleep, and thrust.
that example you showed where putting the tongue to the spot that the body of the tongue can't get to the top causes headaches.
Yes, this causes headaches.
If they're going through therapy, they can't get their tongue up to the top because of the tie. Then
It's just, so because of the tie, because of the space. Because of the tie, so we don't want them to get headaches. They're not doing it correctly. They're overcompensating, and they're not doing natural resting. So a month or two of therapy, even this guy can do a month or two of therapy without pain. We'll release you, we'll get you there, okay? So the trouble I have is with these patients, okay? These patients maybe do therapy for nasal breathing and like jaw mobility, jaw opening, and TMJ pain, things like that. But don't think you're gonna get the back of the tongue up with myofunctional therapy, tongue tie release.
So the case that I suggested to run away.
Yes, that's this one.
Do you think he would benefit from
This case right here?
Yeah. No. Yeah, that case. Right.
I would want to do a workup on it for sure. He's got cranial issues big time. He's got, if you look at his palate, it's in the right hand side of it. That matches the sphenoid bone, which is higher.
I'll tell you, if you put the block, I don't know that much compared to them, but you're increasing the vertical, and that's gonna open the posterior space. So this patient is not gonna tolerate CPAP. Okay, it's impossible, right? It has too much thrusting and too much tension to have a traditional oral appliance where you pull the jaw forward. Not gonna work. But if you can put a block in there, increase the vertical, now you've created space for CPAP to work. Then he gets growth hormone release. He loses weight, and then you manage that for like a year, 6 months a year. Okay, you do jaw surgery on him. I don't know how you guys feel about jaw surgery, but sometimes it's the case for it. Huh? If it needs to be done, great. Okay, fantastic. Yeah.
Make sure it's a uniblock though.
What's that?
Make sure it's just a uniblock on one side to allow us time to be able to keep going forward.
Fantastic. Yeah.
I was just gonna make a point.
Yeah, please.
Preaching to the choir, but when a CPAP is prescribed for a patient like this, if they have obstructions, like who's making the recommendation? Hey, you're probably not going to tolerate it because of this airway issue.
Yeah.
What if we open the bite? Like,
So we collaborate with you on that, or you could manage it. Okay. Even if you come through me, they're buying it online. Okay. It's $1,000 to buy a CPAP online. If you try to go through insurance, it's 2 to 6 months struggle. And it's not worth it. Because then even when you get it, they're renting it to you, charging you monthly $100. And then you meet your deductible, and then you're still paying $30 a month for the rest of your life for it. It doesn't make any sense, from my perspective, to go through insurance for CPAP. But the CPAP will, you keep it under low pressure, it'll help some. It'll take his AHI of like 60 to like 40. Okay, and then you put a bite block, a homeo block in there, and now he's at a 30 instead of a 60. At least he's not dropping into the 70s and 80s, and and he's maybe getting a little bit, like you're moving it forward a little bit, loses a little weight, the little positional therapy. I don't know, huh? It adds up. He doesn't have a lot of choice. Yes.
I've always wondered about this, your perspective
Sure.
of a CPAP.
Yeah, you can get central sleep apnea if the CPAP is on too high of a setting, okay? And if you're using the CPAP through your mouth rather than the nose, the tongue is gonna fall back, not be effective, and you're gonna overbreathe, okay? And the overbreathing will drop your CO2 levels and cause central sleep apnea. So if you, through the mouth, through the nose, maybe it's helping the nitric oxide get in, I don't know, maybe diluting it, not that much, yeah, I don't know. But if you need it, you need it. If you need it, you need it.
Central apnea always secondary to hypothermia?
So the sleep medicine doctors will tell you that it's like benzodiazepine, morphine, like Parkinson's, like stroke and things like that, which they're right, it is, okay? But in the patients that you're seeing in your dental chairs who are coming to you, you're not seeing patients who have stroke and Parkinson's and, you know, CNS depression because of morphine and things like that. Most common in what we're seeing is mouth breathing causing CO2 depression, yeah. And even the sleep medicine doctor will tolerate 25% central sleep apnea to obstructive because of the mouth breathing effect.
So what you're doing is you're stopping breathing to build up carbon
Yeah,
dioxide.
100%. 100%. It's breath hold for sure. Necessary one too, right? It's like life-threatening if your CO2 gets that low. All right, so in adults, we said, you don't want a tongue surgery. This person's gonna head to MMA. Kids are a different story. Kids with open bites, you treat with therapy, okay? Kids get the tongue on the spot. It's gonna do everything for them. And look, this is just with, I think maybe like a myobrace and myofunctional therapy. This is where he started, how it's going, all right? We did the tongue tie release and did really good. Here's another case of a girl who just did myofunctional therapy and tongue tie release. Look at that, amazing. What amazing results we can get when we identify the smoke before the fire. What we have to do is to identify these issues early, look at tongue tie, but also breathing, feeding, sleep, oral habits. In our course, we teach not only tongue tie, we teach how to evaluate for tonsils, how to assess for nasal. We teach you guys how to look in the nose with speculums, and we have a little like otoscope that we give our participants to look in the nose and see, is there allergies there? Is there crusting? Is there bleeding? Should you be using Flonase or Clear? Should you have a polyp that needs to be removed? You guys should be incorporating nasal exams into your practice. Look in the nose, we'll teach you how. Identify the tongue ties, that's how I can help you guys. Here, you know, and then you take other courses to learn about how to do palate expansion in kids and homeoblock and surgery. We advocate for video camera screenings rather than sleep studies because you can see what's going on here. I don't need a sleep study to tell you that either one of these children are in trouble. Even if this child is quiet throughout the night, perfect oxygen, that's still not normal. What's that? That's not normal. You're compensating for a problem. So we'd love to have you guys. I give a 4-day course. The next one is in Marina del Rey. It's December 14th to the 17th. I do have an online course that works well if travel is difficult for you guys. In the in-person course, you get the content and the hands-on. You measure each other's tongue ties. Everyone gets a home sleep study that we review all together. And we look at everyone's CT scan, and you get your hand in people's mouths, and you look in the nose, and you develop some confidence, some confidence. Because knowledge is power, and the mind, once stretched by a new idea, never returns to its original dimensions. There's a lot of people behind the scenes that I want to thank. Here is our clinical and research team. Here are some of the medical assistants. All of our medical assistants are either PA, pre-dentistry, pre-health, and we have like 100% match rate for whatever program that they wanted to attend. We have affiliates like Dr. An, who we're so proud of, who are creating things in a similar vision, and I'm so thankful to be able to come here and learn from you and grow together and do research together and watch all the amazing things that you're building in your community here. So thank you guys very, very much. Please feel free to be in touch, have the slides, let's have some discussion. Good.
Great, thank you so much.
My pleasure.
Does anyone have any questions?
Good, all right.
No? Okay.
Fantastic, thank you guys very much.
Thank you so
Very, very good. Yes, enough to